This is our presentation on delusional disorder. I'm Emily Ellison.
I'm Brooke Polakowski.
I'm Destiny Urich.
And I'm Connie French.
Okay, so to get started, I just wanted to give you guys a brief definition of what delusional disorder is. And it is defined as a type of serious mental illness in which a person cannot tell what is real from what is imagined. And this is referred to as a psychosis. Next slide, please. Okay, so some identifying information. This disorder has many different types, starting with erotomanic, and this believes that another person, often someone important or famous, is in love with him or her. And then there's grandiose, which has an overinflated sense of worth, power, knowledge, or identity. There's jealous, which believes that his or her spouse or sexual partner is unfaithful. Persecutory, which believes that they or someone close to them is being mistreated, or that someone is spying on them or planning to harm them. And then there's somatic, which believes that he or she has a physical defect or medical problem. And then there's mixed, which means that two or more of the delusions listed above were working in a combination of each other. Next slide, please. Okay, so an exact cause of delusional disorder is still unknown, but researchers look at three different things, which includes genetics, biology, and our environment. So as far as genetics go, it's more common in people who have family members with the disorder. And then looking at biology, they look at the imbalance of neurotransmitters and abnormalities of the brain. And then as far as our environment goes, they look at things like drug and alcohol abuse, stress, and isolation. Next slide, please. Okay, so symptoms and presentation. Hallucinations, so seeing things, hearing things, or feeling things that aren't really there. Irritability, lower angry mood, and non-bizarre delusions. Next slide, please. Okay, so as far as diagnostic criteria goes, to start, a full medical history will be taken, and there will most likely be a physical examination as well, just to rule out any other potential causes of the symptoms. And then that will normally be followed by a referral to a psychologist or a psychiatrist, sorry. And then they will do an interview, and like a full interview, and an assessment tool will be used. So an example of this would be Brown's assessment of belief scale. Next slide, please. Okay, so this is an example of delusional disorder from the movie Shutter Island.
Not enough of this bullshit. Where's my partner, huh? Where's Chuck? Where is he?
Let's try this another way. Your wife's maiden name was Chanal, am I correct?
Don't you even talk about her.
I'm afraid I have to. Notice anything these four names have in common? It's your rule of four. Andrew, what do you see?
If you've done anything to my partner, Doctor, that is a violation of...
Focus, Andrew. What do you see? The names have the same letters. Edward Daniels has exactly the same 13 letters as Andrew Ladis. The same as Rachel Solando and Dolores Chanal. The names are anagrams for each other.
Your tactics, they're not going to work on
You
me.
came here for the truth. Here it is. Your name is Andrew Ladis. The 67th patient at Ashcliffe is you, Andrew.
Bullshit.
You were committed here by court order 24 months ago. Your crime is terrible, one you can't forgive yourself for, so you invented another self.
Let's get down to the facts.
You've created a story in which you're not a murderer, you're a hero, still a U.S. Marshal, only here at Ashcliffe because of the case, and you've uncovered a conspiracy so that anything we tell you about who you are, what you've done, you can dismiss as lies, Andrew.
My name is Edward Daniels.
I've been hearing this fantasy for 2 years now. I know every detail. Patient 67, the storm, Rachel Solander, your missing partner, the dreams you have every night. You were at Dachau, but you may not have killed any guards. I wish I could let you just live in your fantasy world. I really do. But you're violent, trained, dangerous. You're the most dangerous patient we have. You've injured orderlies, guards, other patients. 2 weeks ago, you attacked George Noyce.
No, I'm fucking on to you, Doctor. You had Noyce beaten.
Of course I didn't.
Give me one reason why I would even touch him.
Because he called you ladies. And you do anything not to be him. I have a transcript of the conversation you had with Noyce yesterday. This is about you and ladies. That's all it's ever been about.
No, he's saying this is about me and ladies.
When you asked him what happened to his face, he said, now here, I'm quoting again, you did this.
No, he meant that it was my
You
fault.
almost killed him. The warden and the board of overseers are determined something be done. It's been decided that unless we can bring you back to sanity now, right now, permanent measures will be taken to ensure you can't hurt anyone ever again.
Okay, so that was just an example, and now Connie is going to take it from here.
Thank you, Brooke. So as my colleague had stated in her presentation, she gave the example of the Brown's assessment of belief scale. While there's no concrete scale or screen for delusional disorder, I found this predominant questionnaire, which is the brief version of a PQB, and it's a psychosis risk screening measurement tool. This particular screening tool has 21 questions that are answered in a yes or no format. Examples of these questions are, have you had experience with telepathy, psychic forces, or fortune telling? Do you have strong feelings or belief about being unusually gifted or talented in some way? Do you sometimes get strange feelings on or just beneath your skin like bugs or crawling? Do you find yourself mistrustful or suspicious of other people? So should the client answer yes to any of these questions, as you can see by the box example there, another box drops down and asks them specifically how the severity of the impairment or distress is. And this is on the Likert scale. Again, that's 1 being strong all the way to 5 strongly disagree. Again, this is only asked when the original question is answered with a yes answer. Excuse me. The recommended scoring for a positive assessment with this questionnaire would be 6 or more yes answers. And a clinician would be required to further assessment and research to establish a correct diagnosis for the client. A clinician would also find it useful to ask further questions like, how long have you been experiencing these feelings? How often are you having these experiences? When did they start? And possibly the question of, how long have you been dealing with these experiences? When completing this questionnaire, it's important for the client to not include the influence of alcohol, drugs, or medications that were not prescribed for that individual. The link to the questionnaire is listed here below. Next slide.
Okay, so now we're going to jump to the prevalence. The prevalence of delusional disorder is estimated to be around 0.2%. So it's very rare, and that's what a lot of the research emphasized, because due to that, there's not a lot of research on that, which is going to come up more when we talk about treatments. But specifically, it's estimated to be more common in older adults. And in this sense, we're talking about adults in like their later 30s, 40s, 50s, thereabouts. It would not be as common to see someone in like their teens or 20s with delusional disorder. And also there's a connection between family members who have been diagnosed with schizophrenia or schizotypal personality disorders. The most common subtype is the persecutory. In that, again, it relates to someone who is like thinking that someone might be spying on you, such as Brooke mentioned. And then also just to note that the jealous subtype is more common in men than it is with women. And again, the jealous subtype relates to thinking that your partner is being unfaithful. Other than that, though, there is no significant gender differences apart from this that we know of so far. So next slide, please. And then moving on to comorbidity. Personality disorders have a significant link to delusional disorder. Apart from that, again, there hasn't been really any research apart from this. So specifically, the average comorbidity rate regarding that is 51.75%. Even more specifically, to break that down even more, for paranoid disorders, it's about 38%. Schizoid disorders, it's about 12%. Obsessive compulsive disorders, it's about 11%. And avoidant disorders is about 9%. So next slide, please.
So when it comes to the cultural and diversity considerations of delusional disorder, the DSM-5 reports no gender differences in the frequency of delusional disorder, like Destiny was talking about. But several studies have found that erotomania is more frequent in women. And then it talked a little bit about the differences in the comorbidity of affective and substance abuse. Some gender differences, but again, not a whole lot. The DSM-5 states that an individual's cultural and religious background must be taken into account in evaluating the possible presence of delusional disorder. So for an example, Latino Hispanic males who believe in the separation model of acculturation. So like the idea of machismo, I'm not sure if I'm saying that right, but they show symptoms that look like the jealous type of delusional disorder, but it's actually their cultural belief of like men are the strong owners like of the household, and Hispanic women are like submissive and obedient. So machismo might look like the jealous type of delusional disorder, but it's just their culture. Culture has nothing to do with just the disorder. And that's all for cultural and diversity.
Okay, so moving on to treatments. Again, I just want to emphasize that there hasn't been a lot of factual, empirical, evidence-based research for delusional disorder just because it is so rare. That's definitely a hindrance with delusional disorder. There needs to be more research on it, specifically with treatments. What I'll be discussing is going to be mainly really just case studies, because there hasn't been large-scale research and trials for treatments with delusional disorder. So again, keep that in mind with what I'm discussing. If when talking about case studies with a small amount of people, you can't really apply that to a large scale necessarily. So just keep that in mind. But anyways, the first treatment is going to be aripiprazole, and the brand name for that is Abilify. So from here on out, I'm just going to call it Abilify. So Abilify is an antipsychotic, and the reason why that psychiatrists, doctors, that they prefer to use this is that it's easily tolerated. So it's easy for a person to start taking it, and it won't have too many hard effects on them, such as like you have a low chance for side effects. Of course, it's always a possibility, but it's pretty insignificant. No weight gain, no cardiac effects, so it shouldn't affect anyone's heart at all. And it's also not a sedative, so it's nice so people can take it throughout the day and still function, just as normal. So a case example that I have for this, I have 3 of them. This one entails a 60-year-old woman who was diagnosed with persecutory type DD, and again, that's like in relation to thinking of like someone spying on you. She started out with 3 milligrams every day, and then she progressed up to 9 milligrams daily of taking Abilify. That lasted for about 2 months, and she showed significant reductions in her delusional ideation. But however, though, she started experiencing Parkinsonism, and again, that relates to like having tremors. So of course that's a really bad side effect that the doctors and herself would not want. So they dropped her down to 6 milligrams then daily, and after a week of that, there were no side effects, so no more tremors for her. And then she still, though, was able to understand that her delusions, at least some of them, were false, and she was able to start to challenge her beliefs and start to realize that some of her thoughts are delusions. So next slide, please. So then another case example that I have is someone who is 29 years old. So it is a bit uncommon. This is someone who is a bit younger, but they were diagnosed with persecutory type delusional disorder. And again, that relates to someone thinking like someone's spying on you. So in this case, though, it was interesting. He was giving injections of Abilify, which I think is important to note, just because it gives another avenue in case maybe someone can't take medication orally, or they forget to take it. Whatever the case may be, if it's a better option to have it as something that can be injected, it's good to know that this medication can be used like that. And when he was using it, it showed, again, he didn't have any side effects, and he was able to have a better sense of his delusions and realize that, oh, okay, yeah, some of my thoughts are actually delusions. So again, it allowed him to have like a better insight. The third case example that I have is someone who is 36 years old. She was diagnosed with delusional disorder. The medication started with 5 milligrams, and then it moved to 10 milligrams, and then 15 milligrams. So again, it was like a progression. 3 weeks into this, she missed her period, and but she did report, though, her delusional thoughts were being diminished. So she was given a pregnancy test to make sure, she wasn't pregnant. That turned out to be negative. So the doctors then were assuming that it was probably due to taking Abilify. So they stopped the medication then. And then 3 months later, her period returned to normal. However, when stopping it, like her delusions started to increase again. So they decided to start her back on 10 milligrams, so kind of like the middle ground, and kind of see what would happen. At that point, her delusions, they, for the most part, like ceased. However, though, again, she didn't get her period. So in this case, it was best for her to stop it. I wanted to include it, though, just because it does show that, at least Abilify, it does show to decrease delusional ideation. However, though, with any type of medication, it's going to react to people differently. But however, though, it does show that this is still another possible treatment option. So next slide, please. So then the next evidence-based treatment option is cognitive behavioral therapy, better known as CBT. In relation to delusional disorder, CBT focuses on like 3 phases, as it's called. There's preparation for therapy, challenging the delusions, and evaluating a patient's reality. For preparation, again, that's like educating on the client kind of what to expect, making sure they're in a good headspace, and that they are ready to kind of seek treatment. Challenging the delusions relates to, questioning the actual delusion, and kind of challenging that and starting to actually work through the delusion. And then with the evaluating the reality, it's just kind of to check in to see how aware and insightful like the client is with their own surroundings. So one of the studies that I have is that it consisted of 32 participants, and 15 of those were already on medication. So again, that's something to consider. However, though, all the subtypes were present, but again, persecutory was the most common, which makes sense because that's the most common in delusional disorder. So they were randomly assigned to the CBT group or the attention placebo control group, which I'll explain what that is a bit more later, but anyways, that's a control group. So they were involved in individualized weekly meetings for 24 weeks. So this lasted quite a while, and their meetings consisted of having one of 3 psychologists present to do the therapy. MADS and the BABS were given pre and post treatment. And what that is, the MADS stands for Malsey Assessment of Delusions, and it's 53 questions that examines 8 broad dimensions of a person's delusions. And specifically what those are, it mentions like the strength of a conviction, belief maintenance, affect relating to belief, positive actions on the belief, idiosyncrasy of belief, preoccupation with belief, systemization of belief, and insight. So again, it covers a wide area of delusions. And then the BABS stands for the Brown Assessment of Belief Scale, and that's 7 questions that specifically focuses on like the severity of the delusion and how insightful the client is. So that was given the pre and post, and then on top of that, they also administered the Beck Anxiety Inventory, the Beck Depression Inventory, and the Social Self-Esteem Inventory. That was also administered pre and post treatment, just to provide further clarity for the MADS and the BABS. And even on top of that, all the participants were encouraged to write in a diary daily, just for them to personally describe what delusions they experienced that day and how severe they were in their own words. So there was a lot of research done in this study. So next slide, please. Then diving on a little bit more specifics, the CBT, again, that focused on the 3 phases, those being the preparation for therapy, challenging the delusion, and evaluating the patient's reality. And the CBT focused on kind of letting the client like direct the conversation. However, though, keeping in mind those 3 like goals that they have. And in general, the psychologists really work to kind of start linking external stressors to the individual's like emotion and delusion. So kind of thinking like, oh, is there some specific event in your life that maybe might have triggered like a delusional thought to try and start getting the client to realize their own delusion. And then so the APC, that control group, there wasn't a specific therapy used, and they really just focused on immediate problems. What I was taken away from that is that really for the most part, it was just talking to someone about whatever. There was no end goal. There were no set, stages or anything. It's just very generic, let's have a seat, tell me, let's talk about whatever you want to talk about. Anyways, the outcome was that both groups did show improvement on the MADS. However, though, the CBT group, they displayed improvement in the BABS and in the depression / the self-esteem inventories. So that was pretty significant, especially since there's so much like testing that they did before and after. So that was pretty cool to see that. Then also the CBT group were more likely to challenge their own beliefs and act against it. So again, that is quite significant. I also want to add in that this study specifically mentioned a different study that only had 12 participants, but it was set up in a similar way with having like a CBT and APC control group. And again, it showed a similar outcome, that the CBT group, 10 out of the 12 participants showed improvement. So it just, again, to show that CBT is potentially a valid treatment option for delusional disorder. So next slide, please.
Thank you, Destiny. So for our class interaction, what we're asking you to do is to find a website that discusses the Brown Assessment of Belief Scale that that Brooke had spoke about. So we want you to explain the scale in a paragraph, and then we want you to compare the Brown's assessment of belief scale and the PQB that I spoke about, and let us know which one you like better and what's the reason for it. We included the website for the PQB, but we also want you to post the website that you use for the Brown's assessment of belief scale in that post. Next.
Yeah, so what we've talked about so far was the overview of like delusional disorder, going over like the types, the prevalence of it. We showed you like the visual aid just to get more of like an actual like firsthand experience of what it kind of looks like with someone who might have delusional disorder. We went over an assessment measurement, of course, the prevalence, comorbidity, and also we mentioned the cultural and diversity considerations and 2 treatment options provided. But again, I think it's important to just restate again that, you know, there's not a lot of significant research on this yet, just because it is so, it's a quite rare disorder. However, though, it's definitely an area that needs more research in, because just because it's rare doesn't mean that it's not a valid area that should be taken into consideration, especially for treatments. Because if someone is experiencing this, of course, we want to try and help them the best way that we can. So next slide, please. And then these are, oh, it's coming. These are our references. You have just 2 slides of those. And then thank you so much for listening to us.
Okay. Let me stop.
Now